Hello, I'm David Cooper, Vice President of Clinical Development at UniQure, and it's my pleasure on behalf of the company and our investigators and steering committee to present an update on the HD-GeneTRX-1 and HD-GeneTRX-2 phase 1/2 clinical trials of AMT-130 gene therapy for early stage HD. These are my disclosures. UniQure is a pioneer in gene therapy. We have more than 20 years of experience in AAV gene therapy. We have two primary locations. We started in Amsterdam in the Netherlands, which is still home to our research and development groups. In the Lexington, US location outside of Boston, we have development and GMP manufacturing. Just to ground on the basics of what is a gene therapy, it's a technique that uses genetic material to treat or prevent a disease. Shown here in the diagram, it's got a viral capsid, which is sort of like the box or packaging. It has a DNA expression cassette, that's the instructions of what to make. And then the body becomes the continuous production machine that allows the therapeutic molecule to be expressed. Now let's go back and just ground on the Huntington's disease neurodegeneration and how it occurs and where it occurs. So we know that the repeat expansion leads to the prolonged CAG repeat in exon 1 in the HTT mRNA, which leads to the expanded polyglutamine tract in the protein aggregation, and neuronal degeneration. And we also know that the primary pathology starts in the striatum, listed here on the right as 1, moves up to the cortex in 2 and 3, as shown here. So there is certainly a localization in the brain to where the primary pathology starts and spreads to, which is important to our targeting of a therapeutic approach. So what is AMT-130 and how do we deliver it? So AMT-130, also called AAV5 MyHTT, has an AAV5 capsid and then an expression cassette, which expresses a microRNA. It's a replication-deficient AAV5. It targets the toxic Huntington exon 1 using UniQure technology. And it's really targeted towards expressing DNA that expresses a microRNA. How are we implanting it? We're doing a one-time intracranial injection of AMT-130 into the striatum, the caudate nucleus, and the putamen, as shown on the right. To get to our clinical studies, we went through a lot of proof of concept with AMT-130 and gene therapy in animal models. This started with human neurons, where we looked at efficacy and safety. We then went into 5 different rodent models, 4 HD mice and 1 HD rat model, looking at efficacy and safety. And then what's really important is we were able to translate this into large animal models, which we're very thankful that these exist in HD. And this includes non-human primates as well as the transgenic HD mini pigs. And there we can look at distribution, efficacy, and safety. Importantly, since we're doing a stereotactic administration procedure, we were able to perform this parallel procedure in 56 transgenic mini pigs and non-human primates. Throughout all of these studies, we have not shown off-target effects, and we've shown that this therapy has been well tolerated in our GLP toxicity studies. We've continued to follow out some of these animals, and particularly the mini pigs, in long term, and we have trend data out to 36 months now with the mini pigs. What we're able to show here is illustrated in these 3 panels. To the left, starting with CSF, the microRNA against Huntington, MyHTT, which we've shown persists. We've been able to show the knockdown of the mutant Huntington protein in the brain and in various brain regions. Our key area that we're concerned with is the striatum, which is shown in the blue highlight in the middle. And then we also know that neurofilament in the CSF is a marker, and we see a transient effect in the injected animals associated with the surgical procedure, which returns the animal's baseline by about 3 months. So what we've seen in these longer-term experiments is stable expression, mutant Huntington protein lowering, and long-term baseline NFL levels. Ultimately, our goal in this therapy is to maximize the potential for clinical impact, and our approach tries to optimize the benefits-risk trade-off. So we're doing a focused neurosurgical delivery to the most relevant regions, and here we're showing the striatum and then the cortex. We're not targeting 100% knockdown or the entire CNS because we are targeting both wild type and mutant Huntington. We're targeting 50 to 75% maximal knockdown in the striatum, where the benefit risk of knockdown is clear, and only 25 to 50% cortical knockdown by anterograde and retrograde transport from the site of the caudate and putamen infusions. This schematic shows you the brain. In the cutaway that you'll see, there's a focus now on, you can see the caudate, the putamen, and the lateral ventricles. The target is to address the head of the caudate with one infusion, and then 2 infusions into the putamen itself. All of the infusions are approximately 500 microliters, administered under real-time convection-enhanced MRI-guided delivery. So we're actually monitoring this treatment as it's infusing into the brain, and I'll show you some of the real images later in the presentation. Following this, we know there's anterograde and retrograde transport, to which the therapy gets extended to the other brain structures involved in HD. Our ultimate goal of AMT-130 treatment is to slow disease progression. Based on regulatory guidelines, we're starting after patients are diagnosed with manifest disease. And our goal, as these patients would normally deteriorate, is to show that they either stop deteriorating or slow the rate of deterioration. So we're trying to slow disease progression. First, I'll talk about the phase 1 study in the US, and then I'll talk about the phase 1 study in Europe. So the phase 1 study in the US, CT-AMT-13001 or HD-GeneTRX-1, is the first FDA-approved clinical study for gene therapy in patients with HD. The primary objectives of both the US and European study are safety and tolerability of AMT-130 in adults with early manifest HD. The secondary objective is to test the duration of AMT-130 persistence in the brain, and the exploratory objectives are to examine the effect of AMT-130 on biomarkers of HD and assess HD progression and response to AMT-130 treatment. Here are the proof of concept endpoints across our trials. For biomarkers, we're looking at neurofilament, we're looking at Huntington, both mutant and total in CSF, and other exploratory biomarkers. We're looking at imaging, including MRI and MRS, as measures of neuronal function and striatal volume and atrophy. We're looking at clinical parameters, including UHDRS, total motor score, and functional capacity. And we're looking at quantitative scores, including Q-motor, as well as HD-CAB. This is the design of the current US study. This is a double-blind, randomized imitation surgery or sham-controlled study. It evaluates 2 dose levels of AMT-130, 6 times 10 to the 12th and 6 times 10 to the 13th GCs per patient. And that's to target the 50 and 75% reduction in mutant HTT in the striatum. It's administered by one-time bilateral stereotactic neurosurgical procedure in the caudate and putamen via MRI-guided convection-enhanced delivery. The blinded follow-up in this study is 12 months. The total follow-up is 5 years. And we're conducting this in approximately 12 centers in the US, including 3 surgical sites. The general flow, as described, is shown in the figure on the right. Ultimately, there'll be 26 patients enrolled in the study. The low-dose arm will have 6 dosed patients and 4 shams. The high-dose arm, 10 dosed patients and 6 shams. The key inclusion criteria have really evolved over the first year and a half that we've been working on the study. The inclusion include patients 25 to 65 years of age with early manifest HD. The current TFC inclusion is 9 to 13, which is stage 1 or early stage 2. And we currently are including patients with DCL4, motor manifest, or DCL3 who are multidimensional and have either Q80 equals yes on their UHDRS, or have a neurocognitive dysfunction for the MDS task force definition. Patients should have more than 40 repeats, a putamen volume of greater than or equal to 2.5 centimeters per side, and a caudate volume of more than 2 centimeters per side. And this is one of the first HD studies that's actually had a volumetric cutoff. but we are doing surgery, and it's important to make sure that surgery can be done safely and effectively. Stable concomitant medications prior to screening and through the time of surgery for more than 3 months. The exclusions really are related to surgery. We want to exclude patients who have an implanted deep brain stimulator, any relevant brain or spinal pathology, including congenital abnormalities or anomalies, medical contraindications to anesthesia, particularly in the US, because this is a sham-controlled study, and any previous gene therapy or RNA or DNA targeted investigational agents. This illustrates a little bit about our evolution of the inclusion criteria. Originally, the study, based on regulatory feedback, was to have this sentinel group of 4 patients at the beginning with TFC 7 to 10 and 44 or more CAG repeats. And the issue is that this creates a population who we found out has very low striatal volumes. We then revised the criteria to the current TFC 9 to 13 with 40 plus repeats. And what we see is this area in green of TFC 10 to 13 with 40 to 44 repeats are the patients most likely to meet the volumetric criteria. As Dr. Stemming presented at the AAN meeting and then at CHDI, what we find is the total motor score as well as SDMT are the most highly correlated with striatal volume. Total functional capacity was less correlated with volume. And this led us to adapt the criteria to include individuals with earlier disease, including DCL3, and less pronounced motor symptoms. One of the questions we always get is why not reduce the minimum volume criteria? And I think this has 2 important components. One is adequate volume supports safety of surgery. It's harder to target and miss dilated sulci. There's a greater likelihood, if there's atrophy, of unwanted perivascular spread. It's harder, particularly to target the head of the caudate, as shown in some of the trajectory lines 2-dimensionally on the right side, around enlarged frontal horns of the ventricles. And obviously targeting is a 3-dimensional process. And it's harder to target substantive infusions into the posterior putamen when it's very atrophic. The other is that adequate volume supports the potential for benefit. Overall, the more atrophy there is, that reflects the extent of disconnection of structures, so less likely patients will benefit. What we've taken from the surgical procedure is that there's a lot of firsts in doing this. This is the first gene therapy infusion into HD patients. It's the first gene therapy with 6 infusions, 3 sets of bilateral infusions. It's the first convection-enhanced delivery into the caudate. So there's been a lot of firsts here. What we've done as we've progressed is really engaged very thoroughly with the neurosurgical committee, representing all of our US and EU dosing sites to review all the trajectory plans pre-op through the committee, and also review the debriefs after all the surgical procedures before we start the next set. So we're very engaged with the neurosurgeons to optimize how we do the procedure. Here are some real-world pictures from one of the procedures. So the bilateral smart frames are attached through the skin and allow placement of stereotactically oriented holes. A catheter is shown in the middle. These are ceramic smart flow catheters, are placed into the target structures and slowly advanced with a gradation from a very slow initial starting rate of the infusions, convection enhancement, watching these on the MRI, as you can see on the right, until we're able to actually see that we've covered the target structures and we're in the right positions. And this guides any increases in the rate of infusion. Shown here are 3 representative infusions. These are cine videos taken off of approximately 20 or 30 serial MRI scans of 2 to 3 minutes each that are done during the procedure. So we actually will monitor as we're doing the infusions and loop videos so that we can actually watch the progression. And this is as both the catheter is advanced through the structure and then the rate is increased so that we get coverage. And we're targeting about 70 to 75% coverage of the target structures. And this allows us to watch what we're doing in real time during the surgery and make these changes to rate and depth. We've had a lot of progress in the past year, despite dealing with trying to execute a trial like this in the midst of a pandemic. We started in June 2020, right after some of the sites in the US were able to open up. after the initial shutdowns, and we're dosing the first 2 patients. By September, we had a recommendation to continue to the next 2 patients, which were dosed in October of 2020. We then completed enrollment of the first cohort in the phase 1/2 trial in April of 21, and have gotten DSMB permission to start the second cohort in the US and begin the EU study. And the first 2 patients in the cohort 2 with the higher dose were treated in the US in mid-June of 21. So let's just talk for a few minutes about the EU study. The study in Europe and UK is an open label study with 15 participants. It has the exact same inclusion and exclusion criteria as the US study, the same 2 dose levels, the same administration procedure. There's just no sham or imitation surgery. The follow-up will be the exact same visit structure and the exact same instruments over 5 years, the first 6 months of which will be considered post-treatment follow-up and the remainder long-term follow-up. We'll be conducting this at 3 HD centers and 3 surgery centers in the EU and UK, with the UK site being combined as a surgical and referral site. In Poland, we'll be working with the Institute of Psychiatry and Neurology, Dr. Wachowski, and the Interventional Neurotherapy Center at Brno Hospital, Dr. Zabik. In Germany, the George Huntington Institute, Dr. Rallman, and the Heinrich Henning University, Dr. Vesper. And in the UK, we'll be working with Cardiff University and Dr. Rosser and Dr. Gray. We think that between the 2 studies, we will augment our ability to have signal detection. And I think this is very important for us to understand the decision to go into a phase 3 study. We have 26 patients, as I said, in the US study, including 10 sham patients, with a crossover potential after review of initial data. With the 15 additional patients, we'll have at least 12 low-dose patients, and we'll have 19 high-dose patients to compare against the 10 shams, with a suite of clinical endpoints, biomarker endpoints to look at. To conclude, I just want to thank the rest of the UniQure team, thank our AMT 130 steering committee, representing key experts in the US and EU, our neurosurgical planning committee, which, as you can see, includes all of our surgical sites in the US and EU, and the HD community, which has been so supportive of our programs. And to our many, many collaborators, thank you all, and I'll be happy to address questions in real time.